Good morning, everyone. Welcome. Oh, I got a robust good morning from this group. We'll try that one more time. Good morning, everybody. Morning. Welcome to the 2023 Southern Nevada County Health Rankings and Roadmaps. My name is Jessica Johnson. I'm a senior health educator here at the district, and I'll be your MC for today's event. It is my distinct honor to bring this to you again here in Red Rock Conference Room. And have such an incredible collaboration statewide of all the players that you see here on our screen. We're going to start this morning with some opening and welcoming remarks from the Director of Community Health, Dr. Michael Johnson, who's joining us via WebEx. And hopefully the clicker works. Turn it on. That would be helpful, right? All right. Fidel, if you could advance the slide, and Dr. Johnson, the floor is yours.
Great. Thanks, Jessica. Sorry I can't be there with you all. Welcome and good morning, and thanks for attending the County Health Rankings 2023. It's always an exciting event to do each year. For those of you who don't know, the County Health Rankings, which is a program of the University of Wisconsin Population Health Institute, measures the health of nearly all counties in the nation and then ranks them within states. The rankings are compiled using county-level measures from a variety of national and state data sources. At County Health Rankings and Roadmaps, we believe in a future where everyone has opportunities to be healthy and to thrive. Many factors impact how long and how well we live. Our data show how these factors shape community conditions, while highlighting the stark differences in health that stem from injustices and barriers to opportunities. Today, we're happy to have several of our expert staff present to you about our county health rankings. Following me, Benjamin Ashraf and Brandon DeLise will present county health rankings data and interpretations. Carmen Hua will provide an update on Southern Nevada Health District Community Health Improvement Plan, or as we refer to it, CHIP. Stacy Smith, who we're happy to have here, will provide an update on rural Southern Nevada health and wellness initiatives. Xavier Foster will provide an update on SNHD health equity initiatives. And then Ben and Brandon will discuss operationalizing health equity for such conditions as COVID-19, monkeypox, and overdose prevention. And then we'll have some time at the end for questions, which Jessica will MC, and then I have a couple of closing remarks. So again, welcome everybody, and I'll turn it over to Ben and Brandon.
Well, thank you so much, Dr. Johnson, for those opening remarks and getting us started today. As Dr. Johnson mentioned, we're going to start the day with Dr. Benjamin Ashraf and Brandon DeLise from our epidemiology department here at the Health District, who will be covering Nevada County Health Rankings and Roadmaps for 2023. So help me welcome Dr. Ashraf and Mr. DeLise.
Thank you, Jessica, and thank you, Dr. Johnson. So everyone, I'm going to start off by giving an overview of the county health rankings and discussing some of the counties within Southern Nevada. And then I'm going to turn it over to Brandon, who's going to go more into the details on the individual health outcomes and health factors and how our rankings compare to one another, as well as the United States and the national average as a whole. So before we begin, it would be remiss not to mention our various partners that helped us help create this presentation. As you can see, that the county health rankings is done through a collaboration of both local health departments, various universities, as well as local community partners as well. So throughout for this entire collaboration, we're able to produce these rankings for you on a yearly basis. So, you know, we should acknowledge, and I've listed some of the organizations above that have helped with this process. So, as has been the case in the past decade, let me start again, I apologize. I want to take a moment on this slide to highlight the wide range of factors, like how long and how well we live, as illustrated in the model here. Now, what's important to know about these models is that when you get to health outcomes, which is how our health is at the current state, that these are caused by individual health factors that are happening right now. The health factors lead into these health outcomes. So it's important to make this distinction as we go through the rankings. You need to have a clear understanding how the health factors lead into the individual health outcomes. And more importantly, that these health factors are created by policies and programs that are implemented at the moment. Now, to enact the change that we're hoping to see and create a more healthy and equitable community throughout Southern Nevada, we need to enact policies and programs that are favorable towards public health. So, and then, just so you know, that if you're interested in going into more details about the individual county health rankings, including the Cultivating Civic Infrastructure and Civic Participation, which are the new measures for this year, we have listed the county health rankings website on this slide here. So if you go here, you'll be able to go into more in-depth detail about each individual ranking, how it's calculated, and how it's determined. So I'm going to start off with the health outcome rankings. So a little bit of a context for this slide. And the numbers in parentheses are the rankings reflective of 2010. So as you can see how we rank compared to what we rank, to how the counties rank when compared to 2010. As you can see, when we talk about Southern Nevada counties, Clark County, certain counties such as Clark and Lincoln have shown improvement in the rankings since 2010. However, some counties such as Nassau saw a small decrease in their rankings from, as you can tell from the slide. And then also White Pines has been relatively stable over the last, since this comparison was made from 2010. Here we have a visualization of the health outcome rankings. So when you're interpreting this slide, it's important to recognize that the darker shades mean a higher, lower ranking as far as health outcomes, while the lighter shades are reflective of a higher ranking as far as individual counties, as far as health outcomes. Now, as you can see, that there is some trends that you can see here, but the one thing that's reflective to know is that this is just that we can enact policies again to improve these health outcomes as we go forward. And going now into the health factors rankings. Here we see that when looking at Southern Nevada, we see that there's an actual decrease that we noticed from 2010 in the individual health factor rankings. As you can tell, Clark in 2010 was 11, and we have gone down to 14. We're currently ranked as 14 throughout the state. Now, again, as we mentioned before in the slide beforehand, health factors are what leads to eventual health outcomes. So to better address future health outcomes, it's important that we enact policies and programs that can benefit the health factors now during the current time. And on this slide, we have a visualization of the health factors by county. And then again, I just want to show that over here, you can see like in Southern Nevada that that our health factors are a little bit on the lower end. However, what's important is that, with that knowledge, what we can do is we can enact or modify existing policies to better improve these factors in the current state to go forward. And here's a comparison slide of showing where we are as well as health outcomes and health factors. And I'll just give it a moment here, and you can see how we are. And again, I just want to emphasize that this is just how we are now. This is not what's going to be determined, especially in health factors. When you consider that, we have the opportunity to improve. So it's good to reflect on where we are and how we can make those improvements going forward. And then I'm going to turn it over to Brandon.
Good morning, everyone. So my name is Brandon DeLisi. I'm a senior epidemiologist here at the Health District. So I'll be providing data and differences among Southern Nevada counties on health outcomes and health factors individually. So the health outcome bar graphs will be represented in green, as shown in this slide right here. And I'll present these first. And the health factor bar graphs will be represented in blue. So in each of these graphs, the dark columns are the state's 3 urban counties, and the lighter shaded columns are our state's rural and frontier counties. So while there are some limited data on Esmeralda specifically, it has been excluded due to incomplete or unreliable data on most measures. So to make things easier for everyone, Southern Nevada counties will have that red arrow pointing above it, so you can easily identify that. So let's get started. Let's talk about health outcomes, specifically premature death, the years of potential life lost before the age of 75 per 100,000 population. So Clark County stands at 7,362, which is higher than the US average, but lower than the state average and the rest of Southern Nevada. So Nye County stands at 10,837 and White Pine County is at 7,423. Let's move on to low birth weight births, specifically the percentage of live births with low birth weight. So that's less than 2,500 grams. So looking at the bar graph, Clark County lies at 8.8%, which is higher than the US and state average. Lincoln County is at 8%, the lowest in Southern Nevada counties. Nye County is at 9.6%, and White Pine County is at 9.2%. Moving on to life expectancy, more precisely, the average number of years a person can expect to live. Clark County's life expectancy lies at 78.4 years, slightly less than the US average at 78.5 years. Lincoln County has the highest life expectancy among Southern Nevada counties at 81.8 years. Nye County is at 74.1 years, and White Pine County is at 79.7 years. Let's move on from health outcomes to health behaviors. These are measures influencing tomorrow's health as opposed to today's health. So let's look at adult smoking, or the percentage of adults who are current smokers. All of Southern Nevada counties are higher than the US average of 16%. Clark County stands at 16.8%, which is the lowest in Southern Nevada. Lincoln County at 20.1%, Nye County at 22.4%, and then White Pine at 21.3%. So let's talk about adult obesity, or more specifically, the percentage of adult population aged 20 and older that reports a body mass index greater than or equal to 30 kilogram meter squared. So Clark County and Lincoln County are both lower than the national average of 32%. So they are 31.1% and 30.3% respectively. Nye County is at 34.5%, and then White Pine is at 32.7%. Let's take a look at clinical care access. So for those who are uninsured, specifically the percentage of the population under the age of 65 without health insurance. All of Southern Nevada counties are higher than the US average at 10%, but lower than the state average. Clark County is at 13.8%, Lincoln County is at 13%, Nye County at 12.9%, and then White Pine County at 12.6%. With this measure, we are staying within the umbrella of clinical care access, but now looking at primary care physicians. So more precisely, the ratio of population to primary care physicians. So all of Southern Nevada counties are higher than the US average at 1,310 to 1. Clark County is at 1,763 to 1. Lincoln County is at 2,580 to 1. Nye County is at 3,432 to 1. And then White Pine County is at 1,352 to 1, which is the lowest ratio among Southern Nevada counties. So let's take a look at an indicator under social and economic factors, child poverty, specifically the percentage of people under the age of 18 in poverty. Clark County is at 20.6%, higher than both the national and state average. White Pine County has the lowest proportion among those in the Southern Nevada counties at 15.5%. Nye County is at 24.6%, and then Lincoln County at 17.6%. Now let's turn our attention to single parent households, more precisely the percentage of children that live in a household headed by a single parent. Clark County is at 29.2%, which again is higher than the US and state average. White Pine County has the lowest proportion out of Southern Nevada counties at 10.5%. Nye County is at 27.3%, and then Lincoln County is at 30%. The last health factor figure that I'll go over pertains to the physical environment, the severe housing problems. So more precisely, the percentage of households within 1 of 4 housing problems. To clarify, if a household has overcrowding, high housing costs, lack of a kitchen facility, or lack of a plumbing facility, it will meet the definition of a housing problem. So Clark County has the highest percentage in the state at 19.7%. Also, Clark County is higher than the US average. Lincoln County is at 11.1%, Nye County at 16%, and then White Pine County at 9.8%, which is the lowest proportion among Southern Nevada counties. So let's go over and switch gears a little bit and talk about how to take action to improve health. So on the County Health Rankings website, you can find strategies that work, guidance for setting a plan in motion, and then resources to help you partner with other organizations. So I encourage you to get involved. If you choose to, learn to take action, discover what works with you, go to the website right there, countyhealthrankings.org, take action to improve health. And so this is a county health rankings model that you see here. It illustrates how upstream policies and programs can influence public health outcomes, including the length of life and quality of life. If you visit the County Health Rankings website, which is countyhealthrankings.org, you can explore this model. So exploring the different health factor areas like social and economic factors will let you browse the different measures in each county. So if you click, it will be specific to each county that you're looking at. And so this slide represents all the different public health system partners that there are, and then how they are connected to the local health department, like the Southern Nevada Health District. So public health system partners include, fire and rescue, corrections, nursing homes, public transit, drug treatment, and more, as seen right here. And so I really want you to explore the 2023 rankings listed here. Go to the website, countyhealthrankings.org, explore, look at the measures, and then get informed with whatever county you're coming from. So now we will turn it over to the next person.
Wonderful. Thank you so much to Ben and Brandon for an overview of where we're at this year with the 2023 rankings. Fear not, we're going to talk a little bit about some of the initiatives that are happening across Southern Nevada that are addressing many of the things that you heard today. We're going to start with an update on the Community Health Improvement Plan for Clark County, presented by Carmen Hui.
Hi, good morning, everyone. It's so nice to see everyone's faces here today. This front row is lacking, but but yeah, welcome to the County Health Rankings. We're so happy to have you here. But as just mentioned, I will be doing my presentation on the update on our Community Health Improvement Plan in Southern Nevada and some additional updates. But let's get started. So this is today's overview outline of what I'll be presenting on. So I'll be going over the MAPP framework, going over the whole Community Health Improvement Plan, not everything, but you'll see. And then I'll give a brief SNHD reaccreditation update. So let's get started. There's like a ton of information. So yes. Okay, first slide here, I wanted to explain what the MAPP framework is. So it's developed by the National Association of County and City Health Officials, also known as NACCHO. So MAPP stands for Mobilizing Action Through Planning and Partnerships. So this is a community-driven strategic planning process, which aims to improve the community's health. So there's many phases in this whole framework, but the first three actually focuses on the community health assessment, and then the next three, which is boxed right here, it's actually for the Community Health Improvement Plan. But this is actually our where we currently are in the stage, so 6th stage. So this is the action cycle where we're planning, implementing, and evaluating. So this is where we're putting our strategies into action for the next few years and continuously monitoring them as progress as it's ongoing. So yeah, that's a little introduction to what the MAPP is, but it's a whole framework cycle. So to get started on the Community Health Improvement Plan, so if I go too fast or there's way too much information, please check out healthysouthernevada.org. It has a whole report and it has a community health assessment report, which you also want to check out because it links to the community health improvement plan. But it's a great resource, so please check out healthysouthernevada.org. So yeah, and this is also the website where we'll be tracking implementation and progress updates. So you'll want to be here. So I just want to answer the question. So what is the CHIP? So it's not chips you use to eat with guac and salsa. We love that, but it's the CHIP where it's more of a long-term systematic effort to address public health problems based on the community health assessment. So that's the first part. And then it's also an improvement process. So overall, it helps coordinate, sets priorities, as well as target resources. So it's very critical in this process to develop policies as well as define actions that will actually help promote health in our community, as well as aim for clear and specific, realistic, action-oriented goals. So with that, it also has realistic timelines. So everything for the Community Health Improvement Plan was really thought in depth with a huge steering committee that put many hours into coming up with priority areas and strategic goals. So why is it important? So what is this CHIP and why do we even want it? So it's important because after reviewing the data, the primary and secondary data and the community health assessment report, it actually reveals priority areas that are critical in developing and implementing specific strategies for actions to target efforts that promote health as well as establish accountability. So as you saw earlier from Brandon's and Ben's presentation, we actually utilized some data and information from county health rankings to create the community health assessment. So from that data, we create a community health improvement plan. So how will it be used? So it's a very community-driven plan, providing outlines of goals, strategies that can be utilized by coalitions, task forces, organizations, honestly, everyone. So committed partners and just citizens. So it's just a general plan that emphasizes evidence-based strategies. So this will be a guide for organizational level strategic plans across sectors, but also it helps regions to track progress as well as celebrate achievements and changes as the work unfolds over time. So yeah, that is a little introduction to what the Community Health Improvement Plan is and why it's important. Okay, so thank you. So I wanted to share this slide with you all. So this is actually the main goals that guided the whole process. So this was developed by our robust steering committee. So it provided a more of a foundation on what we as a community really collectively wanted the CHIP to accomplish, and just reminding everyone to keep this in the back of their head to guide our efforts. So the bolded words and phrases, they highlight the main points such as reassuring that it's inclusive, enhances opportunities for participation. It has a clear roadmap of addressing inequities, addresses those root causes, utilizes data, as well as ensure that the CHIP is health inclusive, of health equity for all populations, and emphasizes that no efforts are duplicated. So these were the goals that we really wanted to set as our foundation while developing the CHIP. So health equity. So this was a very big component of the Community Health Improvement Plan. I'm sure we'll hear more about it from my colleague Xavier momentarily, but I just wanted to provide some background and foundation on exactly what health equity is to this whole report, because that's what we primarily emphasized it on. So health equity, as you can read, it's achieved when every person has opportunity to achieve their full health and potential, and no one is disadvantaged from achieving this potential because of a social position or other socially determined circumstances. So in general, so each person has a fair and just chance for optimal health. It acknowledges that each segment has differing levels of disparities, and these disparities are eliminated by uplifting everyone to the same playing field. As for equity, the obstacles for health is unique to each group. they're removed. So, for example, lack of housing, lack of healthcare access, poverty, discrimination, and much more. So it gives people tools that they individually need to have a fair chance. But yeah, so health equity has been built into every component of an organization. And as Xavier will most likely mention, SNHD is demonstrating that commitment as they have developed the health equity department here. So wanted to give that insight because I wanted to also talk about how health equity and the CHIP ties in together. So there are 4 foundational principles that we also focused on. So equity, community engagement and collaboration, inclusion, and data and community informed action. So on equity, we really try to encourage shared exploration of social injustices, including structural racism, class oppression, and gender oppression that create and perpetuate inequities. So it mobilizes community action to address these injustices through transformative change to structures and systems that perpetuate inequities and create opportunities for all to achieve optimal health. And then for community engagement and collaboration, we have where we were trying to actively build community power to ensure those most impacted by inequities and actions are addressed through the community health improvement process and those that guide the process. So making key decisions and help drive those actions. And then as for inclusion, this fosters belonging and prevents others by identifying and eliminating barriers to community participation and ensuring that all stakeholders and community partners, regardless of their background or experience, can contribute to the MAPP process. And then lastly, we have our data and community informed action. So this here focuses on identifying priorities, strategies, as well as action plans that are driven by the community's voices and grounded in community needs as identified as a timely, qualitative, and quantitative data. So those are the foundational principles that we also tied into the CHIP. So this is the exciting part. So we have our 2022 to 2025 Community Health Improvement Plan priority areas. Many health indicators are extremely important, but we narrowed down to these top 4 priority areas in the CHIP through a prioritization meeting back in October. So these were chosen by Southern Nevada community members. So number 1 was ranked chronic disease. Area number 2 is access to care. Number 3 is transportation. And number 4 is funding. So I will be going more in depth with each one, but we wanted to ensure that we incorporated equity in every goal and objective as well as the action steps. And then if it's too small to read, you have to check it out at healthysouthernnevada.org. All right, so the first goal area is chronic disease. So chronic disease is extremely large and broad. So, but my subcommittee, the chronic disease subcommittee, really wanted to focus on smoking and chronic diseases related with highest rates identified within the community health assessment. So that was actually heart disease, lower respiratory disease, as well as cancer-related deaths in Southern Nevada. So they also wanted to emphasize and target populations that they saw with the highest rates. So non-Hispanic, Black, and African Americans, 65 and older, as well as by zip codes identified in the community health assessment assessments. So we have zip code maps in the CHA, and they located it by zip code areas. So let's see. Within the goals, you might be asking like, oh, how about maybe obesity, diabetes, and the other chronic diseases associated with tobacco and smoking. So wanted to just emphasize again, these areas are extremely important as well, but we tried to word the objectives strategically, incorporating other chronic disease programs so we can cover a whole broad umbrella. But subcommittee, they brought up a higher normalization in Las Vegas where we have smoke-free industries and how it's acceptable and normative to smoke indoors. And these target populations just showed those high rates to put into perspective. There were 203.4 per 100,000 population deaths for heart disease in Clark County, compared to 164.7 in the U.S. And it was even higher in the Black and African American population for 267.1 per 100,000 deaths. So yeah, but that's kind of what we went off of was the data and the community health assessment. So some of the proposed data and activities and actions, we wanted to continue promoting existing programs, develop trackers for model policy implementation, for the second objective listed up there, and then also working with community health workers for increased health promotion and advocacy. So that's a little information about the chronic disease. But I also wanted to highlight some of SNHD's Office of Chronic Disease Prevention and Health Promotion Department. So some of their initiatives that the CHIP plays to backdrop to enhance the programs and policies. So I got permission to share some of these awesome initiatives going on right now. For example, the tobacco program, it works to expand smoke-free and tobacco-free policies where people live, learn, work, and play. And then for smoke-free housing initiative, there was 6,802 units in REACH zip codes, so 52,492 units total. And then UNLV, Las Vegas Lights, and the Aviators these facilities are all smoke-free, vape-free, and cannabis-free. And then lastly, right there, we have our business expansion. So there are 22 minority-owned Hispanic and African American or Pacific Islander businesses expanded to this tobacco policy. And then just to highlight a few more, the promotion of tobacco cessation. They also developed brands specific to populations who promote tobacco cessation. So Latinx, African American, LGBTQ+, Native Hawaiian, Pacific Islander, culturally, linguistically, geographically, as all tailored material and through the media. So these were just like a few examples that the Office of Chronic Disease have worked on and how they promoted it. So No Menthol May, it's a nationwide initiative to promote cessation in African American faith-based communities. So there are tons of initiatives that our Office of Chronic Disease is working on. So I just wanted to highlight a few. And then, so going on to our second priority area, we have access to care. So access to care, they were a crazy robust group, wanted to focus on every area of access to care, but we have narrowed it down and identified target populations with the most disproportionate rates. So they wanted to focus on uninsured and undocumented populations, as well as the LGBTQ+ population. And the overall focus was focused around stigma and care. So some of the goals, they were primarily focused on reducing medical deserts in Southern Nevada and increasing the number of medical personnel, which include mental health services as well. So increasing patient confidence in choosing primary care physicians was also one of the goals and objectives. And this committee, they thought, how do we increase those numbers? So some of the proposed activities and actions the committee wanted to do was primarily to ensure cultural competency to provide appropriate care, as well as target some training opportunities in the community for medical providers. So collaborating with nearby universities and creating new programs that might help increase mental health providers in Southern Nevada, and even creating a list of guidelines for provider documents, ensuring inclusivity in the region. So ton of information. And then we go into our third priority area, transportation. So for transportation, the goals we wanted to identify were to actually increase the awareness of options available that access basic needs and services. So trying to increase general transportation access and resources available to the community. Transportation does remain a structural barrier as individuals may have insurance and a healthcare provider, it doesn't necessarily mean that they have the means to get to their appointments or reach them in a timely fashion. So we really want to focus on actually accessing transportation to get to those basic needs services. And this subcommittee also wanted to focus on providing more options to the community, such as expanding the Golden Groceries program and Silver Star programs, and letting people know that these programs exist, and that there's so many more programs out there beyond these two. And then another objective and proposed activity I wanted to focus on was actually just submitting more funding requests and searching for more opportunities for our community, trying to reach those disadvantaged populations. And then our transportation group also saw some overlap in needing to apply for more grants, not just relying on transportation, but to build a more robust multimodal transportation system. And those were the main focus areas. And then we have our priority area number 4, which was funding. So funding, I think it's always a risk. It's a huge topic. So funding. Yeah, our subcommittee, we wanted to focus on the overall general increasing Nevada's readiness and ability to be responsive to the health needs in the community. So this committee they really want to just focus on more of a robust public health system regarding funding to increase funding to the state's public health system. So the main objectives were centered around increasing the total amount of funding to the state's public health system. So some context wanted to provide you all is that, so Nevada is actually ranked last for public health funding in the nation. We were tied with Wisconsin at $72 per person. And for reference, the top funded state was Alaska, who received $449 per person. Yeah, crazy. And then the national average was 116. So yeah, put that into perspective. But we just wanted to hope that we can increase state legislator awareness and engagement to develop and implement those advocacy plans, create a more communication and outreach plan to increase those community and stakeholder understandings, as well as address those existing gaps in the community by identifying examples that resonate with community. So those were the 4 priority areas. And if you wanted to read more in depth, it's on the website. But next steps we have here. So we are currently implementing our action plan for this community health improvement plan into action. So we'll continuously update our progress and tracking on our website and dashboard. Yeah, but we are continuing our community partnership and engagement. And actually something super exciting that's coming soon, not quite yet, but coming soon, it's our Healthy Connect newsletter. So this will be a community newsletter that we wanted to provide updates on the health improvement plan, as well as gather some information from community members to see what's going on in Southern Nevada, so we can share the news with everyone. Because I know sometimes people don't always hear about the events going on, so I think this would be a great way to share with the community. That's some exciting stuff coming next. All right, so that was the Community Health Improvement Plan, but I just wanted to give a brief update on our SNHD reaccreditation update. So as many of you know, hopefully, we got accredited last year. So our next steps at the moment is actually reaccreditation. So it just never stops. But year 1, we actually have our first annual report due I think in a few days. But yeah, this year, and we got accredited in 2022 without conditions or recommendations. So from my understanding, we have a submission of a 4-page questionnaire, a brief report on our QI project of our choice. And then I think we wanted to focus on the project at the Southern Nevada Public Health Lab, delivering good results and enabling better turnaround times of COVID test results up to a long-term care facility. And then in our second and third year, we get to choose an option of the theme of the report. And I heard that we intend to submit a more detailed QI report project for 1 or both years per the Public Health Accreditation Board requirements. And then year 4, so this is the year that SNHG actually has an opportunity to upload our full accreditation package for a non-punitive review in 2026. So this is a just a sneak peek to see which areas we have to work on. And then year 5, the year that we actually submit for reaccreditation, this is where we'll upload any upgrades from year 4 for our next 5-year reaccreditation. So this one is actually going to be due at March 31st, 2027. So that seems far, but it's going to come quick. But yeah, what I've heard is that we'll also continue to utilize and revise our processes per the reaccreditation guidelines. But yes, this is our reaccreditation update. And then, yeah, that was it from me. Thank you. Tons of information. Allowed to go on forever, but yeah, I will hand it over to the next speaker. Thank you all.
Thank you so much to Carmen for a very in-depth look at our community health improvement plan. And I encourage all of you to go to the Healthy Southern Nevada website and check out the great work that Carmen and her committee have put together for those initiatives. Next, I would like to welcome Stacy Smith from Nye Communities Coalition. Stacy will be highlighting rural Southern Nevada health and wellness initiatives that her group leads. Help me welcome Stacy.
See if I can get this to move. There we go. I am from Nye Communities Coalition. We serve the counties of Nye, Esmeralda, and Lincoln, and you can kind of see them there. Takes up that southern part of the state, excluding the Clark County area. We've just celebrated our 20th year this last December, and so we've been enjoying that process of growing with our local communities and being sure that we're providing the best care that we can to all of our partners. We started out focusing on substance misuse when we originated 20 years ago, but we've quickly transitioned into quite a few of the areas that we've been talking about today. We've got a fairly broad focus, and so as we go through some of these slides, y'all will see some of the services that we provide throughout the communities. We do have some programs that reach into some of the other counties. We've reached down into Clark County on some of our projects too. And so you may hear me mention some of the other service areas, but for the most part, we focus on Nye, Esmeralda, and Lincoln. As you've heard today, we are typically, if you look at the map that they provided earlier to you, typically Nye County does land in those lower areas. And this has been true. I've lived in the community for almost 30 years now and have written grants in the area for almost 30 years now. And that unfortunately has been a lot of our situation where we have resided down towards one of the poor ranking counties. On the other service area, on the other end, is Lincoln County, who has typically progressed and been in the higher ranking areas. We have seen this drop during this last year, and I'm hoping to work with Brandon and some of the others to really dig in. I know some anecdotal reasons why that ranking is dropped, but I'm going to want to dig in and try to get a better understanding of what's going on in the community. Esmeralda, as they mentioned earlier, is not ranked. The reason for that is just a low population. The population of those 3 counties together runs right around 55,000 for the whole service area. And Esmeralda's usually got a population of 750 to 800 people. And so it's just not a large enough community for us to gather data on. The county health ranking models that they talked about earlier there on the left-hand side takes the model, and as I think it was Brandon was mentioning, if you click on the tobacco use and the diet and exercise, you can really start digging into some of those measures. And so what we do is we follow the 8 dimensions of wellness, and you can see that there's a really good correlation between the 2 models of what we use on the right and what the county health rankings uses on the left. As we start looking at some of those data and really digging into them, What I did was I pulled our reports from this last year that each of the grant managers did. And so you're going to see where Brandon and Carmen kind of started digging into where the data's at. Now you're going to start seeing how we actually put that into play in some of our communities. And so we're going to be talking about the actual programs that we implement. I'm going to be showing you some of the outcomes that we've had and some of the projects that we work on. In the general, it's good to know that NICC is a real broad-based organization. We wear a lot of hats. We'll take on a project for a while. We'll sometimes get it up and running, and then we'll turn it over to another agency or organization, either within our community that exists already, or we'll help grow that. We do this because it may not be in our best interest or the community's best interest for us to manage it for the long term. The programs that I'm going to be focusing on over the next few slides are going to be the ones that we expect. We delivered them last year, and we expect to continue to deliver them within the next foreseeable future. I'm going to dig into these, and so we're going to look at some of those specific measures. Let's start looking. So the first one that I'm going to take, and if you'll remember back to that model, if you look at the healthy behaviors, and then you go to the tobacco use, the measure that they relate to that is adult smoking. This is a couple of the programs that we operate that addresses that adult smoking. We have the youth vape prevention, and then we have the CDC tobacco prevention grab. We promote the My Quit, My Life text line. We facilitate community conversations about vaping, and we implement some peer and youth education. We promote information and messaging. We do a lot of social media, a lot of marketing, and we work with our partners on developing policies, systems. We change environments so that there's less accessibility to use tobacco, and so that eventually, by reducing, primarily working with youth, we eventually reduce those adults that are going to be using tobacco. The next area gets into the healthy behavior section of diet and exercise. There are several measures that NICC works on, including physical inactivity, access to exercise opportunities, food insecurity, and limited access to healthy foods. We do this by bringing in resources from the Emergency Food and Shelter Program. We act there in that capacity, similar to here in Las Vegas, where the United Way subgrants that money out. We do that similar process where we receive the money from the feds and then we subgrant it out to some of our partners. We support seniors, especially through COVID. We were providing purchases of food and actually delivering it to some of the seniors that couldn't get out to get the food. Our SNAP program provides programming such as Bingo Size, the Produce Pick of the Month, Cooking Matters, Eating Smart, some yoga, some Qigong, walks in the park with docs, those types of programs. We've also implemented a gleaning program. We've got quite a few growers throughout Nye and Esmeralda, growers of food. And so we've implemented a gleaning program where if there's food that's left over, you know, from somebody's personal little garden or even a ranch that we have there, then we'll take that and we work with our food pantries and they put that food back out into the community. Across all three of the counties, we convene and support the volunteer food pantries. Nye, Esmeralda, and Lincoln have no open to the public food pantries that are businesses, that are agencies. They're all done through our churches. So as y'all are probably aware, when you're operating something through an all volunteer base, there's a constant turnover. There's sometimes some systems issues. There's some problems with data collection, skills levels, things of that nature. NICC serves as the backbone organization to those churches predominantly, and we help provide the data collection, help them implement their systems, and then we write large grants where we bring enough food in and then distribute it out throughout the 3 counties. We also will convene collaborations among those pantries so that they are operating in the best interest of the community. We had problems where we only had pantries open Monday, Wednesday, Friday when we started this about 15 years ago. And so what we've done is try to work with all of our church partners so that they know, okay, the Methodist church is open on this day, Baptist church is open on this day. And so then people know where they can go and then they communicate with each other so that everybody in the community can go and access the food on any given day that they need to. One of the other sections is the healthy behaviors, the alcohol and drug section, drug use section or misuse section. This is one of the areas that is probably our highest focus level. We address the measures of excess drinking, alcohol impaired driving, deaths, and drug overdose deaths. With these sources that you see here and with some others and some projects that we implement, our sub-grant funding to partners where they deliver research-based programming out to the communities. We work to reduce the stigma using media and community presentations. We provide the naloxone trainings with the support of the Southern Nevada Health District. We'll just recently, for example, with the naloxone training, we educated 21 people in Panaca, which is a small community in Lincoln County, at their Ward Relief Society. And then we had 24 people that work at the Holiday Inn in Pahrump, and we were able to provide training to them. So going out to those individual businesses, agencies, and partners, and making sure that they're trained on naloxone so that wherever an overdose happens, we're going to have people in our community that can support it. We work a lot on changing policies, systems, and environments so that we remove any barriers that are keeping people from accessing services. And then we try to increase the capacity within our communities to deliver those health and wellness behaviors. We have youth teams, as you can see in the bottom right hand. That trailer that you can see there is called the DPET trailer. And this is decorated. Once you open up the sides to it, it looks like a bedroom. And so when we have our youth team that's trained, and then they educate adults, teachers, parents, church leaders, anyone that's going to be interacting with youth. And so we will be able to take that trailer all over the counties. We pull up, and then the parents come. Our youth talk to them about the way that drugs look, the way that they're transported, the way paraphernalia looks, how it can be disguised or hidden, either purposely or just because it is different looking than some of our generation used to see drugs. And so they'll take them through this little bedroom that's in the back of that trailer and let them see what, how can you use a vape to consume marijuana? And so there's a lot of ways that people use substances now that is very different than the way that some of their parents or even their grandparents knew. So being able to educate them like this helps the parents see what they need to see in their kids' lives. We work closely with all of our partners on monthly meetings, and we take this data that we gain through these county health rankings, and we share it with our partners and present it, and we discuss the data. And then we try to dig into what does the data actually mean at a local level? And then what can we do with that data? How can we prioritize? And some of that Carmen started talking about with how the Southern Nevada Health District is digging down into the issues and starting to set up plans. That's the same thing that we all do in our rural communities, is taking the data, understanding what's going on, and then where is the most bang for our buck? What can we start implementing so that we can make the most changes in our areas? One of the other areas that we address under the healthy behavior section is sexual activity. And the specific measures that we look at are sexually transmitted infections and teen births. NICC has 3 projects specifically focused in this area. We deliver 2 research-based programs. That's the PrEP program, Positive Prevention Plus, and the Teen Outreach Program. The Teen Outreach Program is an abstinence-based program, and we deliver that in conjunction with the schools and some of our other partners. And the PrEP program is a medically accurate sex ed program, and we work with our workforce and some other community-based programs to deliver those. In both of them, youth learn leadership, decision-making skills. They engage in service learning with one of them. Both programs are focused on teens and goes up into young adults. We also have a family planning grant. With that, we're able to provide education, awareness, some marketing, and some promotions around healthy sexual behaviors, in addition to doing some testing and treatment and providing some support for family planning. With our clinical care, access to care and clinical care, and the quality of care is the measure that we address underneath that. Usually this is done in a supportive or promotional manner or by creating the space for these measures to occur. Through the Systems of Care grant, we work with the Division of Child and Family Services, and we have our community health workers. We have a pretty robust group of community health workers that serve rural Nevada, and they link children to mental health services. Our diabetes, chronic disease, and dignity heart grants have also community health workers, and they deliver research-based programs to community members to help them manage their diabetes, to manage their heart disease, and other chronic conditions. We also help community members access their health insurance, and we support them in their applications that they have to fill out. Some of those are pretty cumbersome, and so they take a little bit of support in getting them all done. We also provide a lot of trainings. We do that for including mental health first aid, the assist and safe talk suicide prevention trainings, and some psychological first aid. We provide those trainings to school personnel, bus drivers, teachers, law enforcement, church leaders, anyone that's interested in attending. One of my very favorite things that we do is in the top right-hand side, and that is the remote area medical. We just completed our first event with this in Tonopah, where we served about 179 people. But we do this every October in Pahrump. And what that is a group out of Tennessee that comes in. They bring an 18-wheeler that they roll into your community with. If you're the host group, you can kind of see it there about halfway down in that top right-hand side. That 18-wheeler is just packed to the brim with everything. We set up at a high school, and we basically converted into like a medical MASH unit. And we set up about 30 to 40 dental chairs, dental units. UNLV is a huge supporter. They bring out a lot of their third-year students, and we have other dentists that volunteer their time, and we're actually able to provide extractions, cleanings, fillings. We've even been able to do some denture repairs and new dentures this last year. We also have a full-on medical unit, so we take a classroom, we put up bays, we put in exam tables, and we provide women's health, medical care. People have been diagnosed with diabetes. There's been a pre-diagnosis of cancer or screening that ended up over the time, turned out to be screening, or turned out to be cancer. We have mental health and psychological assessments that occur during the event. And the cool thing is, in addition to, I mean, all of it's really cool, but what I really love is at the back of that truck, once they pull everything out, is a full-on vision lab. And so the patients come in that day, they're able to get assessed by ophthalmologists and optometrists. They get their prescription and they go and pick out a pair of glasses from the hundreds of pair of glasses that are available. And those glasses are cut on site, and they're given those glasses by the end of the time that they leave. Remote area medical is a huge benefit to us because one of our biggest issues is primary care. Healthcare, mental health care, specialty care. Most people in rural recognize you're going to have to travel for that specialty care, but we are having and have been having huge issues with primary care. And so there are many people that are using our events as their primary care, not just because of lack of insurance or coverage, but because of lack of providers. This October will be our 9th event. We expect to serve around 300 people in Pahrump, and that converts to just over $100,000 worth of medical care that happens over a 2-day period. They roll in on Thursdays, we set up on Friday, and we deliver care on Saturday and Sunday. One of the other areas is the social and economic factors, and specifically we're looking at education there. And we address some of those measures in that area through our Safe Schools before and after school program that we offer at all of the elementary schools in Pahrump. And that's primarily focused on tutoring and educational attainment. We employ licensed teachers and offer other learning and fun activities to about 500 students before and after school in Pahrump. We also provide workforce programming for youth across 9 Esmeralda counties, giving them the support to complete their education, get paid work experiences, receive career counseling, And those lead to a variety of opportunities for employment and other educational learning activities. Most of y'all are probably familiar with the Southern Nevada Workforce Connections, and that's our funder in that situation. You can see some of the kids in the bottom right did some of their service learning projects. And then that young man there in the top one was able to attain his associate's degree in college. Next area is social and economic factors, and this includes the measures of employment, income, and family and social support. Our adult workforce program provides career counseling, support for employers, job search support, and extensive training opportunities. We also have a Brownfields grant that training is actually going on right now as we speak. And we've got about 25 people with that. And the purpose of the Brownfields grant is not just to get them training that eventually can lead to employment, but also for all communities to have a cohort of people that are ready to respond in case of some sort of disaster. We've got 25 people right now being trained on asbestos today as I speak. The next section is the social and economic factors. And in this, community safety is another area where we're addressing several of the measures. Suicide prevention and awareness is a huge priority for 9 Communities Coalition. Our Together with Vets program offers support and training. And we've been able to set up suicide prevention or awareness clubs at 3 of the schools that's in our service area. We also provide some crib safety, provide the parents with cribs, and we also provide car seat installations, inspection, and we'll provide a car seat to someone that is needing it. One of our fastest growing programs is our FAST deflection program. This is a program where I know y'all have some here in some same efforts here in Clark County, and there's others throughout the state. And this is where we are trying to implement mental and behavioral health support with law enforcement. And so we work alongside law enforcement in our communities. We go into the jails. We make sure that people, as they are getting ready to leave the jail, are provided the support and given the access that they need and the linkages that they need and the support that they need so that they can transition out successfully. We're also in the process of developing what the state is calling the MOST team. And this is like a crisis intervention team where we're going to have social workers and our community health workers traveling alongside law enforcement, supporting them as they go about and intervene with people that are in crisis, whether it's mental or behavioral health in our community, and trying to prevent the incarceration of those people and encourage a healthy response. The final area is the physical environment, the air, water quality, and the housing and transit. We support these 2 measures through community meetings to gain an understanding about our housing issues. Our VISTAs and our AmeriCorps members especially focus on housing, and they support local organizations that are working on housing stability. We've got 2 larger organizations that serve 9 Esmeralda communities that are focused on housing and especially focused on supporting the homeless communities. Our community health workers help those agencies and help our community members by providing information, linkages, and support for housing referrals, and for local transportation needs across that area with our mobility management project. This is my contact information. And as much as I could cover about us as quickly as I could in this situation, this is also some of our team members that helped prepare all of these reports. And if you have something specific that you'd like to talk to them about in regards to the areas that they each cover, you can reach out directly to them or to me at any time. I'd also encourage you to look at our website, and especially that newsletter section and that calendar section that can let you know if you're coming into our service area. We would love for you to come and visit us, see us, and join in some of our events. Can't tell you how much I appreciate coming today and being able to share what we're doing in the rural communities. So much of what happens here in Clark County also impacts us in Nye and Esmeralda and Lincoln County. And we really appreciate the data that y'all share with us and the opportunity to be here.
Thank you. A big thank you to Stacy Smith from Nye Communities Coalition for just an incredible, robust presentation. I always feel much more informed and educated and always impressed about what's happening out at Nye Communities Coalition. Our next presenter is Xavier Foster. He's going to talk about the road to health equity here at the Health District. Help me welcome Xavier.
Before I start, I'm gonna have to apologize. I've been having issues with my voice. So you're gonna get a mixture of Barry White and Kermit the Frog today. I'm gonna try my best. As mentioned by Jessica, my name is Xavier Foster and I am the Health Equity Coordinator here at SNHD. Today, I'm gonna briefly touch on a funding overview, some of the grant and program activities, and answer any questions that you may have for me at the end. The work carried out by the Health Equity Program is currently funded by two CDC funding streams. The first one is the National Initiative to Address COVID-19 Health Disparities, and our program falls under strategy number 3, which is infrastructure support. And the second one is a brand new funding stream, which is for strengthening the U.S. public health infrastructure, workforce, and data systems. And under that funding, we fall on strategy A1 and A2, which include workforce and foundational capacity. More specifically, to strengthen community partnerships and development and engagement. Some of the activities under the COVID-19 health disparity grants help not only fund the health equity positions here at SNHD, but are help fund positions in the community throughout 10 community organizations, as well as help us build capacity and expand the community ability to answer to issues such as COVID-19. And under the new public infrastructure grant, is going to continue to provide support for our staff in addition to, in addition to working with new or existing community partners in the implementation of health equity strategies to provide or expand services and assistance to individuals within specific racial, age, income, ethnic, and or geographical location. During the first year of this funding, which is a shorter year due to getting the grant and get it going, we will be partnering with 3 community-based organizations and implement 3 community health strategies that include access to care, transportation, and connection to care in the community. What is important to note in this strategy is it will allow us to not only provide services, but it will allow us to collect data at a community level that will then help us inform future health strategies in the community. Some of the grant activities include, or in addition to the disparity grants, include helping infrastructure projects coming online. We will continue to focus on organizational capacity by providing training, technical assistance, and conducting community outreach. Some of those examples include collaborations with our Ryan White program in their HIV reduction or HIV stigma reduction program, as well as providing support to our Federal Qualified Health Center and their partnership with the City of Las Vegas in their health literacy program. Next steps is just continuing to provide support and technical assistance to our programs internally, continuing to expand on partnerships. And for future steps, we are in the process of applying for the new funding by the Department of Health and Human Services for teen pregnancy prevention program, which was the program we had prior to the pandemic. So that's one of the new fundings that we'll be looking forward to implement soon in the community. And this is my information if you have any questions. Thank you.
Thank you so much to Xavier for highlighting some of the incredible efforts that his team is working on here at the district. No event would be complete without bringing Ben and Brandon back up. I'm thinking of it like a sandwich here. They're going to talk a little bit about operationalizing health equity in some of their areas of expertise. So specifically COVID-19, MPOX, and overdose prevention. So help me welcome back Ben and Brandon.
Thank you, Jessica. And so I just want to give a little context on this presentation. So as we heard from Xavier, and a lot of our other speakers, the emphasis on health equity. And then also, so one key factor to remember is that data drives all
Ben and
aspects
Brandon
of
back up.
achieving health equity. From not only identifying the problem, but also, going through the intervention phase, providing context for that, identifying potential gaps, and addressing those gaps as you go forward. So, as Jessica alluded to, we're going to try to touch on health equity using some of the areas that both Brandon and I are a little more familiar with and have a little bit more experience with. So hopefully you'll be able to see how data and how important data is for achieving health equity in the following slides. Oh, I already went through my first slide. All right,
Ben and Brandon back
I'm going to
up.
start off with COVID-19 vaccination. So obviously, we're still in the middle of the COVID-19 pandemic on a global scale. However, we have come a long way since we initially started. So on this slide, you see a couple different charts, and this is kind of like a snapshot in time. On the left-hand side of the chart, you see where we were last year. Around this time last year, we administered a total of 3,367,238 vaccines throughout the county. And you can see the percentage for certain key population groups, whether they're racial or ethnic identity groups or certain age
Ben and
groups.
Brandon back
As far
up.
as those who have completed the vaccination series at that point, and those who received that initial follow-up dose, which was that first booster in 2022. Now, let's take a moment and just jump forward to now. So when we look at it, it's March 24th, which was only a few days ago, we've come a long way. We've administered over 4 million vaccinations of COVID-19 vaccinations. Now, obviously things have changed. We have another vaccination. We have a bivalent booster. So that, that obviously has made the difference as far as those numbers that you see. However,
Ben and
you
Brandon
can also
back
see,
up.
if you look on the charts on the right-hand side, that we also were able to increase that percentage of the population that's been vaccinated, not only for the follow-up dose, but also for those who completed the series, for those select population groups. However, there's still more room there's still more improvement that needs to happen. Obviously, you can tell with the bivalent dose, the percentage is a little bit on the lower end as far as people who have taken part in that bivalent dose. So there's still more room that needs to take place as far as the COVID-19 vaccination efforts. So,
Ben and Brandon back up.
how has SNHD sought to address health equity concerns during this time? Now, there have been various departments and offices throughout the whole health district that have been addressing COVID-19. It's kind of an all-hands approach when the pandemic started. However, for the sake of time, for the sake of time, I want to try to focus on two in particular, our Office of Epidemiology and our Clinical Services team. So, as far as our Office of Informatics and Epidemiology, we have continued to maintain a COVID-19 dashboard, which not only reflects aspects of COVID-19 cases within the county, but also vaccinations.
Ben and Brandon back up.
You'll be able to see how vaccination rates and case rates differ across different racial and ethnic identity groups, as well as different age groups. And on top of that, our office has also shared data with a variety of different departments throughout the health district, one of which is our clinical services team, which I'm going to start going into now. So Obviously, clinical services have been kind of the front line as far as administering the vaccinations out in the community. In particular, our COVID-19 outreach branch, who have been out there going along with our other clinical services teams and going out into the community. During this time, our clinical services teams have focused on key populations. Now, some of these population groups are a little bit more they're a little bit more underserved than when we think of underserved populations. Some examples are homebound individuals, those who live and reside in long-term care facilities, historically underserved communities, and also homeless populations. And also, just so you know, I want to acknowledge the help of our great community partners during this time as well. Along with our own efforts, our community partners have been instrumental in getting us out into these communities. And we couldn't have achieved those vaccination numbers without them. And then it's key to remember that vaccines are provided at multiple clinics throughout the county. And they have been continued to be provided at multiple clinics throughout the county. And this comes from the data that EPI provides to clinical services. Not only do we provide them data on vaccination rates in certain key population groups and how that changes, so that gives them an idea of like, okay, we know certain population groups are maybe on the, we may need to focus on them. And then that allows them to work in the community, find areas where they can achieve the best outcomes for those groups. But also we give them information regarding where past clinics have been as well. So they know like if there's certain zip codes or certain locations which have been a little bit more underserved or don't have as readily as access to vaccinations as ready as others. So they're able to, plan accordingly. So, but that's not all that has been done to address health equity concerns. Our COVID-19 vaccination branch has also has continued to maintain efforts on reaching out to providers. For those of you who do not know, providers, provider recommendations and having the ability to administer the vaccinations on sites are key motivators for uptake within the community. However, based on recent data, as of March 27th, there is 239 providers within the county that are enrolled to administer COVID-19 vaccines at their office, but only 46 have inventory out there. So that shows that there is a need to increase its uptake if we're going to try to increase the overall uptake of the vaccinations. So that's some of the new efforts our COVID-19 vaccination branch has been working, is trying to get out and trying to recruit providers, trying to understand the barriers that they're facing. And also so we can better address their concerns on administering the vaccinations in office. So this is a crucial step as we move forward into this next phase of the pandemic, is that we have to understand the barriers that the providers are facing and also understand their willingness to recommend the COVID-19 vaccine if we're going to actually continue to increase the vaccine uptake within our community. Now, I'm going to take a moment and shift gears to Mpox. So Mpox has been the other vaccination campaign that we've been experiencing in Clark County and throughout the country. So if you recall, on June 28th, the U.S. Department of Health and Human Services declared a national vaccine strategy for Mpox. Now, if you see this image on the left, the bar graph with the line on top of it, after this announcement, we saw an increased demand for vaccinations as the rise in confirmed cases occurred within Clark County. Shortly afterwards, we saw the increased demand for vaccinations, which makes sense when you think about it. More cases, people are going to be more interested in vaccinations. However, over time, you can tell that this vaccination demand dropped as the confirmed cases dropped from Mpox as well. Now, why is this problematic? Well, Mpox is for those of you who don't know, Mpox is a 2-dose vaccination series. So if people are perceiving that the threat of the cases are a little bit on the lower end, they may not come back to get that second dose and complete their series. So that decreases their overall protection they have for future outbreaks of Mpox. So as this became more apparent, in later December, there was a new strategy that was implemented towards Mpox. And this was done in conjunction with several different departments and SNHD, including our Office of Acute Communicable Disease and Control. Now, this new strategy was to go out into communities that are at higher risk for the disease and actually provide the services to them, whether these are in locations that they're more likely to visit And as you can tell from the little pie chart on the right-hand side, these ACDC population clinics are signified with 105 doses administered since December 8th. Now, when you take that in conjunction with community partners, which are working more with the communities at higher risk, this accounts for almost half of the Mpox vaccinations administered in Clark County from this time period. So this shows that there's a shifting strategy towards Mpox vaccination clinics. Initially, we were able to have those big clinics where we'll have that initial demand where a lot of people are interested in getting the vaccination. However, as time goes on, we had to switch to more targeted locations and targeted vaccination sites so we can better address those concerns and get that completion rate up for the disease. All right, so now, to end my part of this presentation, I'm going to give a few recommendations. So as we go forward into this new year, we need to have a continued emphasis on should be placed on the bivalent dose uptake for at-risk groups, especially groups that are those that are, that might have worse outcomes towards COVID-19 when you think of those who are immunocompromised, those who are those who are our senior population, those 65 and older. And then one potential way we could do this is instituting a potential reminder recall program for COVID-19 vaccinations. If we're able to create create an effective reminder recall program, this can be a way of reaching out to those communities and telling them, hey, there's a new dose available. Why don't you come back and try to help them schedule that appointment? Also, we need to continue to host vaccination clinics for hard to reach and underserved populations for COVID-19. As we know, as you may recall from the previous slide, some of these populations include homebound populations and those who are homeless. Now, primary care services may be harder for these populations to reach, so we have to be able to get out into the community and provide them those vaccination services. And this can be done through cooperation with our existing community partners as well. Also, a better understanding for potential barriers for providers should be pursued for COVID-19 vaccinations. And this is with respect to both the recommendations as well as from the providers and the administration of vaccination as well. Because we want that buy-in for the whole population, make it part of the regular routine. We want COVID-19 vaccinations not to be this out there as a separate thing. We want it to be as part of the regular vaccine schedule and make it a part so it'll be more accepted in the population. And finally, future Mpox vaccination efforts should reach out to populations at risk. And that's something that we need to continue with that strategy of going out to the communities that are at risk, offering them the vaccination so we can continue to improve that completion rate of the disease. And with that, I'm going to turn it over to Brandon.
So good morning again. My name is Brandon DeLisi, Senior Epidemiologist, and I will be speaking about drug overdose deaths with a specific focus on fentanyl deaths. I will be presenting local data pertaining to drug overdose deaths from all substances, pivot to talking specifically about fentanyl, and then about what the health district is doing to address the epidemic and their recommendations with equity in mind. So let's first talk about what we know about drug overdose deaths in Clark County. So most fatal drug overdose deaths are unintentional, including overdose deaths involving fentanyl. And so we can see that with this slide right here. And so the top line is representing all drug overdose deaths, and then the green line is representing the unintentional drug overdose death rate. And so let's take a look at the drug overdose death rate among Clark County residents by drug class 2011 to 2022. So in 2022, excluding the overdose death rate for all substances represented in black, the top three substances with the highest death rate are all opioids represented in that light blue color, psychostimulants, which includes methamphetamine, and that's represented in that light red, orange color, and then synthetic opioids, which includes that drug fentanyl, and that's represented in that dark red color. And so being that we are seeing marked increases in fentanyl deaths, especially since 2015, let's take a look at additional fentanyl-related data, starting with 2022 fentanyl overdose deaths demographics among Clark County residents. So 49% of the fentanyl deaths were among people who were white and Caucasian, so non-Hispanic whites. 24% were among individuals that occurred in people who were Hispanic, and then 20% of the deaths occurred in people who were Black or African American. The majority of fentanyl deaths occurred among males. 67% of the deaths in 2022 were men, and then 33% occurred in females. And so now let's turn our attention to fentanyl overdose deaths by age group among Clark County residents for 2022. So the age group with the most deaths were 35 to 39-year-olds, followed by 40 to 44-year-olds, followed by 30 to 34-year-olds. So looking at the data, such as what I presented in the past two slides, as well as incorporating social vulnerability indices, we can start placing more attention on health equity within across populations, and that would likely have a positive impact and effect on downstream factors, including mitigating the causes of drug overdose. So the health district is combating the opioid epidemic on many different fronts with many different strategies. So the health district has distributed the opioid antagonist naloxone throughout Clark County since 2018, distributing over 45,000 different doses to the community. The health district has also distributed over 42,000 fentanyl test strips to the community since 2021. The health district has also been a strong advocate for public health vending machines, which distributes harm reduction materials, and our staff has been integral in the placement of those public health vending machines throughout Nevada, placing those 7 different machines. In the Office of Epidemiology and Public Health Informatics, where I work, we routinely conduct surveillance on many different drug overdose indicators, including hospital discharge data, EMS data, death certificate data, and then poison control data, and then many more. So the health district also has partnerships with many different public health, public safety, and justice involved entities on many different initiatives to help contribute to mitigating drug overdose deaths. So this is just a snippet of what we do to combat drug overdoses and the overall drug overdose epidemic. So, but for the sake of time, I will move on. And then in summary, so opioid overdose is a public health issue. Fentanyl is increasing at the local level. The highest frequency of deaths occur within residents who are men, those who are Caucasian or white, non-Hispanic, and then the individuals age 35 through 39 are most affected. So increase in fentanyl deaths in the community warrants additional investments in overdose prevention and response. The health district has resources to prevent and respond to opioid overdose. And then, so if we were to provide recommendations, those would be that we would need an improved detection of overdose outbreaks to facilitate more effective response, safer prescribing and more education on the risks of consuming opioids, improved access to substance use and disorder treatment, expanded distribution of naloxone and overdose prevention education, criminal justice reform to prioritize connecting specifically individuals to treatment. So that's really important. And then a comprehensive and coordinated approach is needed and must incorporate innovative and established prevention and response strategies, including those focused on polysubstance use. You know, now incorporating the substance fentanyl, we are seeing that time and time again. So incorporating polysubstance use and the substance use involving fentanyl would be very important going forward in Clark County. And so I would move to providing closing remarks by Dr. Johnson.
Yes, thanks, Ben. I appreciate it. Or Brandon, sorry. I just want to give big thanks today to everyone for their time coming to this event, and especially a big thanks to all the presenters. I think they did an excellent job. The new data and measures, as has been mentioned, are on countyhealthrankings.org in case anyone wants to check it out. Let me turn it over to Jessica Johnson for any questions, and hope you all have a great day and the rest of the week. Thanks.
Thank you so much, Dr. Johnson. Hope this is still on and you can hear me okay. All right, wonderful. Doesn't have the reverb that I'm used to. So thank you everyone for staying, for participating, for hanging out, for being here, for clapping, and one more round of applause for our presenters. So I have some good news and some better news. So the good news is after we wrap up, there is a lot of snacks over on this table for your enjoyment. A big thank you to Jacques and the community health group for putting all of those snacks and treats together for everyone who's here in person today. The better news is we're going to take questions from the audience before now and then. So hopefully you've been tracking your questions from the very first presentation all the way through now. And I would welcome, I'm happy to walk around with the microphone so that we can have these heard by all folks who are in the room. And at the conclusion of today, folks will also be available for one-on-one conversations or interviews for some of the media folks who are here, but wanted to just open the floor and hear from you all for questions for any of our panelists. And presenters, you do have microphones in front of you. They should be active. The little green light should be on. So I'm happy to run the microphone your direction or have you respond directly. So questions. I'll start here and then go back there.
Hi, I think this question might be for Xavier. You talked about the COVID infrastructure money, and I know that part of the COVID response that we've always practiced was the text that went out automatically for folks to talk about, their quarantine protocols or isolation protocols and things like that. So I just wondered if there's room with that technology to expand that idea to our other programs. For example, the monkeypox outbreak, and possibly have a texting service that's an opt-in thing for any of our clients that come in and utilize any of our programs, that could just be something in their documentation that they opt into. And then we have, immediate access to a lot of our clients to send our own messaging directly to them. Because during COVID, for example, there was a lot of distortion of our messaging and the public health messaging through other media sources and things like that. So I'm just wondering if that would be an option, given we have that infrastructure money, to maybe develop something more robust in that type of technology for all of our programs.
I don't see how that couldn't be something that the organization could do. I can't speak directly to that because my involvement in the infrastructure was to increase capacity of community-based organizations. So I think there may be other people in the room that I'm looking at that will be able to answer that question in a better way.
Thank you, Xavier. Wonderful. I have a question in the back over here as well.
Jessica. So I'm going to first answer that question. So we do have some, so texting is kind of problematic, of course, because of HIPAA issues, but we do have our EMR platform called ECW, where we do have capacity to be able to do texting through that platform. I think it really depends on whether or not the clients who receive these vaccinations are actually inputted into ECW. And Sarah, is that done in the field or not? It's still being worked on. Okay, so there's potential for being able to do texting, reminder, recall through our electronic medical record, provided that our clients who get vaccinated in the community actually have their data put into that system. Second question, my question is to Brandon. So we're hearing a lot in the news now about the potential availability of naloxone over the counter. So what do you think the impact of that's going to be on fentanyl overdoses here, and what how is that going to sort of change you guys' strategy for responding to this?
So we here at the health district do distribute naloxone or brand name Narcan. So anybody who is interested in obtaining naloxone can go to our pharmacy and collect a few kits. I think they distribute up to 2 kits per individual. If anybody does want more, they could always request more, and then the pharmacy will be able to give that person what they need. If somebody is interested in specifically obtaining a training, they can email od@snhd.org. And then with myself or a colleague of mine, we can train them, going over what naloxone is, how to respond to an opioid overdose, and then when to use naloxone. We can cover those topics and then distribute naloxone to them up to, a few doses, 1, 2 doses. Even, if they wanted more, we could obviously give them more if they wanted that. So that is available to the public. So all they have to do is email od@snhd.org, and then we can work with them to obtain training and then obviously obtain the medication naloxone hydrochloride.
I guess my question, Brandon, had to do with a recent announcement about the availability of naloxone that could be available over the counter in pharmacies and other places, and what you think the impact of that's going to be, not only on the epidemic here, but also in terms of some of the programs and services that you guys provide here.
So yeah, that I received that email this morning that it was going to be over the counter. So my hope is that the price for naloxone will decrease and then more people will have access to that. But that doesn't change the fact that the health district still does distribute naloxone for free. And so if anybody does want Narcan nasal spray, that they can come to the health district, go to our pharmacy, get a few doses for free. And if they want a training, they can email od@snhd.org to receive that free training.
Thank you so much. Other questions from the group?
In relation to Narcan, so how effective is that on the recent kind of uptick in the inclusion of, I think it's down xylazine, that's being put into the fentanyl? How effective is that? And then my second question is with relation to xylazine, for the number of fentanyl deaths that you displayed above, what's the percentage that included that substance?
So xylazine overdose deaths is something that we haven't really seen here at the health district. We've, if I recall, we had 1 overdose death pertaining to xylazine. And so we do see a lot of individuals overdose on xylazine and fentanyl on the East Coast, specifically in Pennsylvania. So we are prepared for that. But over here in the West Coast, specifically in Clark County, we haven't really seen that. But we are prepared to make individuals aware of what those risks are. But yeah, specific to xylazine, we haven't really seen that here. But we are adamant in providing these prevention responses and activities to individuals that can prevent these overdose deaths, and making people aware that xylazine and or tranq is very risky and very deadly. And so we here at the health district are making people aware that this is a very dangerous activity, and that we are continually trying to make people aware of the dangers of tranq and or xylazine.
Sorry, the second part of that question I think was about, does naloxone work on xylazine, or is there an overdose reversal medication?
Yeah, so naloxone only works on opioid specific compounds. So if xylazine was mixed with, so xylazine is an animal tranquilizer, so it's a non-opioid tranquilizer. So if somebody was overdosing specific on xylazine, naloxone would not work. But typically what we see is people overdosing on xylazine and fentanyl. And so naloxone would work specific to the fentanyl aspect to that drug mixture, but it wouldn't specifically target xylazine. So individuals who are mixing xylazine and or fentanyl, naloxone would work on fentanyl, but not on xylazine. So there needs to be more awareness that, naloxone only works on opioids and not on all substances that suppress or depress the respiratory system, which is often confused. So again, yeah, naloxone only works on opioids, including fentanyl, but not extended to xylazine.
Thank you. Did that answer your question? Okay, great. I have one more question in the back here.
Good morning. Thank you for an amazing presentation. Mine's kind of a big picture question, I guess. I'm looking at, the health rankings and some of the factors that were discussed. I'm wondering overall, how did COVID-19 impact those rankings? Because I wonder, like some of the major population centers like Clark County and Washoe, I wonder if they were disproportionately impacted by COVID and if that impacted things like life expectancy and some of those other factors. And I don't know if that was taken into account with the rankings.
So, thank you for the question, Afi. I know last year that COVID-19 was considered with respect to the health outcomes, with respect to life expectancy, and also with, in particular life expectancy. However, to my knowledge, I'm not sure if that was also taken into account with the county health rankings of this year. What I can do is I can follow up with you. I will go and I'll try to figure out if that was factored into the life expectancy outcome, and I'll definitely get back in touch with you about it.
Great, thank you. Other questions? Great. More questions than last year. A+ audience.
Hi there. Is this on? My voice is just really low. So I have a question in regards to smoking, because from my understanding with the presentation, it was measured for 21 years old and above. Is that correct? So I was wondering, what are the programs available for the kids who are smoking and vaping? Because I know that it's rampant right now in schools. So I was wondering if there are any availability in programs and their accessibility to the youth.
Great question. Carmen and Stacy, I think both of you touched on that. Would you like to talk a little bit more about that?
Sure. Across Nevada, the My Quit My Life hotline is available. And so teens are able to access support through the hotline. And then individual schools will have programs that they implement. I'm not familiar with any of the ones here in Clark County, but I know that there are coalitions and prevention providers that implement programs in the after-school programs, the before-school, and in the school settings, and in the boys and girls clubs across the state that address tobacco cessation and tobacco prevention. So I'm not going to be familiar with Clark County, but Nye County, we primarily rely upon the My Life, My Quit.
Hello? Oh, hi. So as for Clark County, I would believe our Office of Chronic Disease and Prevention and Health Promotion will have more information on youth smoking. Primarily for the Community Health Improvement Plan, we focus on the older adult generation, as well as Black and African American. But I can get back to you on those programs and initiatives for the 21 and younger.
Thank you. Other questions from our very curious group today? I love it. We had an increase of 400% of questions from last year. Great job.
That's good.
Wonderful. Dr. Johnson, if you're still there, I don't see any other hands up in the room.
Okay. Yeah, I'm happy for all the great questions. That's great. And yeah, to the last one about smoking and tobacco use, I would recommend that Malcolm Allo and Maria Israeli, who's the manager of the Office of Chronic Disease Prevention and Health Promotion, would be your best resource for that. And you can contact myself or Jessica for their contact information.
Wonderful. Thank you so much, Dr. Johnson. And I just wanted to thank all of you for joining us today for the 2023 County Health Rankings and Roadmaps. I'm grateful to all of the folks up here today who gave a wonderful, robust presentation of the work happening across Southern Nevada, not only from the data perspective, but also the programs and practices that we're engaged in. We look forward to you joining us this time next year for the 2024 rankings, and I hope that you enjoy the wonderful refreshments that have been provided. Thank you so much for coming.
Yes.